protozoa, or parasites, viral microbacterial infections. We're going to talk about several things today. Typically, when we think about parasites, we think about them in terms of poor and underdeveloped countries or when people travel overseas. But in fact, parasitic disease does affect millions in the United States as well. Several go unnoticed because they're a lot of them are asymptomatic or have little symptoms, but some can cause serious illness, blindness, seizures, and even death. Anyone, regardless of race and socioeconomic status, can be affected, but minorities, immigrants, and those who live in disadvantaged communities do seem to be at an increased risk. Fortunately, many of these are preventable. So here is basically our category of infections we're going to try and cover today, with the exception of TB, because you went over it in Clin Med 1 last year. So we'll start with the definition of a parasite. A parasite is an organism that lives in or on a host organism to get their food and nutrition at the expense of the host. So these little greedy suckers taking what we have to eat. Let's see. All right, we're going to start with helminths, which are worms. This is the world's most common parasite. They will feed on you and also cause weakness, poor nutrition, disease. The worms and the larvae, or their eggs, typically live in a small bowel, so we call these intestinal parasites. Some helminths are very large. Some can measure up to 1 meter, which is about the size of a baseball bat or guitar, living in your stomach. The most serious helminth infections are usually acquired in poor or subtropical areas. Exposure to infection can be influenced by climate, hygiene, food preferences, and contact with vectors, ticks, mosquitoes. Most of them can be eliminated by our immune system. Others can persist for years. You might hear me say light or heavy, small or large, and that is in terms of the amount of worms. So light and small is just a few worms, whereas heavy can cause obstructions and a range of symptoms. This fun little guy. All right, so the 3 most common types are nematodes, cestodes, and trematodes, also known as roundworms, tapeworms, and flukes. They are characterized by various features. The cestodes and the trematodes are hermaphroditic, so they carry both male and female sexual organs. The nematodes are either male or female. They are differentiated based on their features. Some are flat, some are round and cylindrical, some are segmented, unsegmented, and it depends on what attachment organs they possess. Like this one has suckers and spikes. That's a tapeworm. Others have lips and teeth and hooks, so they are pretty interesting little organisms. We'll first discuss roundworms. These are cylindrical, as you can see in the picture. They're round. These are pretty much our big worms. They are categorized into intestinal and invasive types. The invasive have the ability to invade tissues outside of the intestines, so they can go beyond the GI tract. The last one, angiostrongyliosis, we're not going to really discuss in detail. That's the rat lungworm. Its disease can mimic appendicitis and as well as encephalitis. Eosinophilic meningitis. We're not going to really talk about that one. It's extremely good. Yeah. I do believe there are resources at the bottom for that, though. So the first one we're going to discuss is ascariasis. Ascariasis is caused by ascaris, which is the most common intestinal helminth. It affects about 800 million and causes about 10,000 deaths annually. This is a soil-infested helminth. Prevalence is usually high where there's poor hygiene or sanitation, or where human feces are being used as fertilizer in the ground. This organism enters the host through contaminated food. So with ascaris, basically its eggs hatch in the small intestine, penetrate to the bloodstream find their way to the lungs, and then they travel up the trachea. Patient coughs, you cough, you automatically don't swallow. So you swallow it back, it's back to your GI where it becomes an adult worm. These are our large roundworms. This one can grow up to about 40 centimeters, which is a little bit over a foot, or about the extension of these two fingers. This is the worm. These patients are usually asymptomatic, especially in light infections. Symptoms can depend on migration. So if the worm does travel to the lungs, patients may have fever or cough, shortness of breath. If they travel to the GI system, you may have symptoms regarding abdominal pain. Heavy infections can cause bowel obstruction. They can also cause issues with the common bile duct, pancreatic duct, and appendix. So if you're having issues with all of those sites, what other symptom might you suspect? Maybe nausea, maybe vomiting. With heavy infestations of mass worms, like the heavy infection, sometimes these can lead to death. Interesting thing about this one, the adult worms may migrate and be coughed up. They can be vomited or emerge from the nose, mouth, or anus. This is diagnostic. You see a worm coming out of somebody's nose. It's more than likely a roundworm, and it's Ascaritis. You can also identify the eggs using the feces, using a stool sample. Imaging will show worms on a contrast study. And your treatment is going to be albendazole, mebendazole, or parental malate. The first two probably should not be used in pregnancy. So your differential for ascaritis is going to be the other worms that we're about to discuss for the most part. It could be other parasitic infections, but it just depends on the shape and the size of the worms. This one's pretty easy to diagnose. You see this in the clinic, you know what that is. Can you just skip it? We're gonna skip. Let's move past that. All right. That's the ascaritis. That's the roundworm. That one's coming out of the nose, the mouth, anus, throat, vomited. You know, that's the most common one. I should take it all day. Trichoriasis is caused by trichoris, also known as the whipworm. This is also another soil infested helminth. So again, for developing countries, human feces being used as fertilizer, same thing. This is acquired in the same way, usually with contaminated food. Infection is usually heaviest in children, most frequent in children. However, most individuals are asymptomatic. These larvae hatch in the small intestine and mature in the large bowel, so they pretty much stay in their GI tract. They do not typically migrate through the tissues. The interesting fact with the whipworm, which I don't need you to memorize, is that with this worm, some patients experience nocturnal passage of stool, so they have a bowel movement in their stool. Again, diagnosis is going to be with identification. You may see the adult worms in the stool, or you could do a sample and test the eggs. With this one, eosinophilia is common. One of the complications is something called Laffer syndrome, which is a transient lung disease that causes like an irritating cough and substernal burning. It's not working, so I have to use the mouse, but the GI symptoms we talked about, abdominal pain, you also may have senescence, diarrhea, distension, nausea, vomiting, diarrhea, blood and mucus, that should be on the slide. All right. Toxopariasis. This one you may have heard of. Toxocara is the infectious agent. It is affected, about a billion people are infected worldwide. This again affects children, caused by Toxocara canis and Toxocara cati. This is caused by the ingestion of eggs contaminated with dirt containing Toxocara eggs from infected dogs and cats. So a little bit different, this one. In the US, 5% of dogs are infected, and this is most commonly seen in puppies versus older dogs. Direct contact with infected puppies and kittens are classically not considered to be a risk factor because these eggs have to lay on the ground for several weeks before they're infectious. Typically, we'll see toxopariasis when humans work with or play in dirt, or it could be accidentally ingested, like a playground or a sandbox, like you see the little girl in the picture. Typically, this is asymptomatic. Some symptoms might be fever, cough, wheezing, lymphadenopathy. You'll see eosinophilia again. These larvae do migrate. The liver and lungs are most commonly involved. When the larvae migrate, it can cause two conditions, visceral and ocular larva migraines, which we're going to talk about in a second. Patients may present with hepatosplenomegaly or uveitis, vision loss. You would confirm this with serology, checking for those antibodies in the blood. A little bit different with this one as well. Treatment, if severe, you're going to treat it with the same albendazole and mebendazole. For patients who have ocular larva migraines, they may use corticosteroids in addition to those antihelminthics. Human disease is best prevented by periodic treatment of puppies, kittens, nursing dogs, and cat mothers. You want to prevent defecation in play areas if possible. So this one's a little different than the first two, so your differential is a little bit different. This is trichinosis, which is part of our invasive group. The first is trichinella, or trichinosis, they call it. This is caused by the ingestion of undercooked meat, particularly pork or game meat. This is found in pigs that feed on garbage or other meat-eating animals. Bear is pretty common, wild boar and cougars. Very rare, few cases over the past 40 years. Who eats cougar? Typically, the risk of contracting this from properly prepared pork is low now that they got certain standards in place. Undercooked wild game, particularly bear, does put patients at additional risk. Most of these patients are asymptomatic. But if you had a group of like a family that ate their game meat that night, you would expect them all to probably have some type of symptoms, just like we do with the salmonella and the potato salad that we put down. So you would expect family members to have similar symptoms. This one really depends, the symptoms depend on how much eggs they ingest. So if they have more larvae, then they're gonna have more symptoms. Some of the symptoms could be nausea, diarrhea, vomiting, fatigue, fever, and abdominal discomfort. as well as myalgias, periorbital edema, splinter hemorrhages, uncommon myocarditis, pneumonitis, and meningoencephalitis. Eosinophilia again. This is common in these worms, roundworms. So the course usually is uncomplicated, self-limited. If you have systemic symptoms, any of those myalgias, periorbital edema, you need to treat, again, albendazole and mebendazole. You're seeing a pattern here. To prevent, you want to cook the meat to safe temperatures. Color is not good enough, especially with game meat. Color is not a good indicator of doneness. So you need to actually have a temperature, a thermometer to measure that temperature. All right. Let's do our roundup on roundworms. What are common? With the exception of trichinosis, which is your pork and game meat, what age group do you expect to see these in more commonly?
Children.
Children. True or false? Most patients are asymptomatic.
True.
As the body tries to respond to infection, these white blood cells increase. What are they? Eosinophils. Great. And the treatment is typically two things. What? And mebendazole, absolutely. Those are your go-tos for the worms. For the roundworms, at least. We'll do hookworms next. There are two types of hookworms, ankylostoma and Necator. Estimated 500 to 700 million people in the world are infected, with 65,000 deaths. This is common in the tropics and subtropics. So there's higher prevalence in sub-Saharan Africa, Asia, Latin America, and the Caribbean. Eggs are passed in feces of an infected person. Eggs hatch when they're deposited on warm soil or sandy areas. It's a little bit different. Warm soil or sandy areas. The larvae can last for weeks. They can penetrate the skin and migrate to the bloodstream, into the lungs, destroy the alveoli, and carry the cilia, by the cilia to the mouth. Once swallowed, they hatch in your stomach and suck the blood out of your intestines. Once mature, they release eggs and they keep the cycle going. Most are asymptomatic, but some patients may present with cough, blood-tinged sputum. If it's their first exposure to the worm, they may have GI symptoms. A pruritic macular rash, sometimes we call this brown itch, you're gonna see a picture in a second, may occur at the site of larval penetration.
Oops. I don't.
The most serious effects of hookworm infections are blood loss leading to anemia, in addition to protein loss and malabsorption. Diagnosis: eggs can be detected in the feces. Positive fecal occult blood test. Labs may show microcytic anemia, hypoalbuminemia, and then with migration, there may be eosinophilia. Treatment: albendazole, mebendazole, parental camoate. So you still see that, what we're treating is pretty much the same. So when you think of hook, think about sinking your hooks in, sucking blood, anemia. Okay, that's what I think. Some patients with anemia may need iron supplements in addition to your treatment with the anti-helmintic. All right. So this is cutaneous larva migrant. When the worms migrate through the skin of the host, they can cause this condition. Most common in children, extremely itchy, and typically on the hands and the feet. Without treatment, usually the larvae die and are absorbed, and it just goes away. You don't need to do anything. So this picture is of an 18-month-old boy brought into his physician's office for an itchy rash on his feet and buttocks. The first physician examined the child and made the incorrect diagnosis of tinea corpus. He was treated with topical clotrimazole, which did not help. The child was unable to sleep because of the intense itching and was starting to lose weight secondary to his poor appetite. He was taken to urgent care where the physician learned that the family had just returned from a trip to the Caribbean prior to the visit to the first physician. Oops, somebody didn't ask about travel history. The physician was told the child was playing on the beaches that were frequented by local dogs. He or she recognized the wavy pattern of the cutaneous larvae migraines and successfully treated them with oral ivermectin. So that was just their choice of treatment. For test purposes, remember benzazole, RNA, sorry. But that, you can't really forget that picture. You see that, you should be thinking of her. Tapeworm will be the next one. Let's go into our cestodes, our tapeworms now. You're leaving nematodes, roundworms, and moving into the tapeworm. Fun times. All right, the longest tapeworm ever removed from a human was 82 feet long.
No.
82 feet long. This was in a patient in India.
Oh,
And if you measure 82 feet, the closest thing I could find was the wingspan of a Boeing 737.
you're kidding.
So that wrap.
It has nice.
Unbelievable.
How did they pull that out?
The patient had been complaining of abdominal pain for several months and was.
I'm sure it was.
Really?
You don't say.
About 20 million people in the world are infected with tapeworms. They can live inside of a human for more than 25 years.
Oh my God.
Fortunately, this is considered rare in the United States. So tapeworms are flatworms. If you look at that bottom picture, they're very flat, almost ribbon-like compared to that roundworm, which was much thicker, more rounded. An adult tapeworm consists of a head, which you'll see on that other diagram, a neck, and a chain of individual segments called proglottids, in which the eggs form in mature segments. This will help you characterize this from differentiated from other worms. If it was flat, segmented, proglottids, if they mention any of those words in your test, then you know what that is. Proglottids are tiny pieces of the tapeworm that patients can pass, so it might look like a little piece of rice in school. I said, like, oh, there's like pieces in my school, then that might be what they're seeing. There are 6 types of tapeworms that infect humans frequently. They are characterized by large or small. Do not try to memorize these sizes. This is just for a reference. Before, we're going to talk about our beef, pork, fish, and pork. So there are intermediate hosts and definitive hosts. An intermediate host is where the parasite grows from an egg to larva. And the definitive host is where that larva then becomes an adult. So you'll hear some different things like a definitive host is a da-da-da. So the first one we'll talk about, like I said, we'll talk about Taenia saginata, which is the beef worm, Taenia solium, the pork tapeworm, Diphyllobrothium latum, which is the fish tapeworm, Hymenelepis nana, which is the dwarf tapeworm. To me, my crazy brain, when I try to memorize the differences between the Taenia saginata and the Taenium solium, I think a sagging udder when a cow needs to be milked. So cow, cattle, beef, okay? And then Taenia solium, pork tends to have a higher quantity of sodium, and that looks like sodium. So if that helps you remember it, take it instead of throw it away. These are larger in size as well. The beef, most common in cattle breeding areas, usually from eating raw and undercooked beef. So that medium steak might have a little, depending on what area you're in, if it's the infestation going around. These can grow up to 25 meters, which is the width of an Olympic-sized pool. So still pretty big. These are large tapeworms. The pork tapeworm is transmitted to pigs that ingest human feces. These patients may acquire this by eating undercooked pork or ingesting food that's been contaminated with human feces containing the worm. These are smaller, growing up to about 7 meters, but still decent size. The fish tapeworm is caused by ingestion of undercooked freshwater fish. You're gonna see all of these on your chart on the next slide. In the small tapeworm category, the only one we're gonna look at is the dwarf tapeworm, Commonolepis nana. This one's pretty small, grows to about 25 to 40 millimeters, which is about the standard size of an Apple Watch. So a lot smaller compared to these others. Usually those are found in warm areas among persons who live in institutional settings, poor sanitation. Usually this is ingested with food that has been contaminated with feces. So we'll take a look at the chart on the next slide, just so you can kind of put everything together. There are some differences which I have highlighted for you. You can see that most of these are asymptomatic. Possible GI symptoms in all three. You see the source for most of those. Eosinophilia, common in the beef. Proglottids in the stool in all three of those. We'll look at dwarf in a second. For pork, it may lead to cysticercosis. Cysticercosis is a parasitic infection caused by the worm that infect the brain, muscle, and other tissues. When the cysts are found in the brain, it's called neurocysticercosis. And this is typically found in low-income countries, and it is a major cause of adult onset seizures. It is the single most common infectious cause of seizure in the US. Cysticercosis. Cysticercosis, that particular condition of this worm, is not from undercooked pork. It is only from the fecal oral route. Cysticercosis, where it migrates to the brain and other tissues, is only from the fecal oral route, not from undercooked pork. The prevalence for cysticercosis is highest in Mexico, Central and South America, the Philippines, and Southeast Asia. So typically, probably not going to be an issue here, but something you should be aware of. 20 million people infected yearly with cysticercosis, mainly in those high prevalence areas. There is a resource at the bottom of that cysticercosis if you want more information. For the fish tapeworm, you'll see highlighted megaloblastic anemia and neuropathy from vitamin B12 deficiency. Important to remember, these worms can absorb B12 from your intestines. So if you have someone with anemia, neuropathy, and you want to put this on your differential if you're not for sure what's going on. Especially if they've had recent travel, went on a hike, went camping, those kind of things. For the dwarf, they're a little bit different. Again, these are our small tapeworms. The only tapeworm that can be transmitted between humans, which is not necessarily because the pork can have fecal oral as well. But you want to remember that one with human feces, food contaminated with human feces, and again, similar GI symptoms. So nothing too special about that. So try to remember, where you would obtain it, and then all of the symptoms are pretty much the same. The proglottids in the stool, cysticercosis, and the anemia and neuropathy are your keys for differentiating between those. Treatment is an identification of eggs or proglottids in the stool. You may need a CBC. And what would we look for in a CBC? Eosinophilia, megaloblastic anemia, signs of that. And we might want to check on B12, might show abnormalities. The treatment is with a single dose of praziquantel, and you would need to treat the patient and then repeat the treatment in 1 week. There are alternatives, but remember praziquantel. It can be difficult to distinguish tapeworm-induced B12 from pernicious anemia, so that is on your differential in addition to these other things. I did put other tapeworms because you're probably going to be trying to figure out which one it is. So all the other tapeworms and then these conditions with that pernicious at the end. Rheumatoids, we're not gonna talk about a whole lot. These are our flukes. They are flat leaf-shaped parasites, and you see how tiny they are compared to that point. These are rare, so this is more just information. Fasciolophiasis, schistosomiasis, that is in the bottom in a resource. There's some things on that. You may just want to look at it. The first one is interesting because it's from uncooked plants. Water chestnuts, bamboo shoots, and watercress, often seen in South and Southeastern Asia. Can be common in U.S. travelers or immigrants. The schistosomiasis is mostly seen in Africa, and this is caused by drinking infected drinking water, or fresh water that's been contaminated with by snails that drop their eggs in it. Treatment for those are rather as well. Rare, this is more FYI. All right, so you have a 20-year-old college student who returns home from a camping trip with her friends. They were camping by a freshwater lake where they fished and canoed. Since then, she reports feeling tired and fatigued. On physical exam, she appears pale. Her basic laboratory evaluation is sent, which includes the CBC, and this reveals a megaloblastic anemia. Subsequent labs reveal vitamin 12 deficiency. You should know what this is. What do you suspect is the likely etiology? Which worm? Fish tapeworm, yeah. And what's the likely treatment? Praziquantel. Remember roundworms, albendazole. Hookworm, albendazole. Tapeworm, praziquantel. So this is a popular one. Enterobiasis are our pinworms. This is a fun one. You might see in bees. There is a life cycle resource at the bottom that shows you how it's done, but the eggs typically hatch in the duodenum and the larvae migrate to the cecum. Females mature in about a month and remain viable for about another month. During this time, they travel to the anus and deposit, often at night, large number of eggs on the perianal skin. They have a short lifespan, so they continue to reinfect and reinfect and reinfect. Enterobiasis is caused by Enterobius vermicularis, can't say that one, vermicularis, which is a common cause of intestinal infections worldwide. Maximal prevalence, school-age children. So you see the theme here, children for most of these. It is the most common helminthic infection in the U.S., affecting 40 million. Transmitted person to person via ingestion of eggs after contact with the hands or perianal region of an infected individual. Food or fomites that have been contaminated by an infected individual. Infected bedding or clothing. Autoinfection also occurs from poor hand washing and contact with certain objects. So they're scratching, bottoms all night long, wake up, go eat your breakfast, don't wash your hands. Get some travel of eggs to your stomach. The bed is infected, the clothing can be infected, all of those things. And this is what parents come in complaining about. Won't stop scratching her spot. Most patients are asymptomatic, but the itching is super common. Nocturnal perianal pruritus due to the presence of those eggs on that skin. This can cause insomnia, restlessness, and enuresis in children. This is not uncommon. The scratching can result in excoriation and impetigo, which we are familiar with. Diagnosis. Pinworms are usually not found in the stool. They are found on the skin. Not in the stool, on the skin. Eosinophilia, rare. I'm not seeing that with this one. Skin, not the stool. A common test is to apply clear cellophane tape to the perianal skin, ideally early morning, followed by microscopic examination of eggs, which is what you're going to look at on the next slide. So basically, you're gonna put that cellophane tape right in the anus. You're gonna do that 3 times, typically. The sensitivity of the test is reported to be at 50% for just one test, 90% for 3, which is why we're gonna repeat it. Nocturnal examination of the perianal area or gross examination of the stool may reveal adult worms, which you see a picture of at the bottom. They're only about 1 centimeter in length. So if you check the crack, basically, at midtime, you might see those little worms. Treatment should be familiar to you. Single oral dose of mebendazole, parenteral pamoate. And you want to repeat this dose in 2 weeks. All members of the house should be treated concurrently. All members of the house should be treated concurrently. Be part of your patient education. Treat everybody in the house. Treatment of all close contacts may be appropriate when rates of reinfection are high, such as schools, things like that. So not just people that live in the house, but everybody the child has been around in a close proximity. Hand washing after defecation and before meals must be stressed to limit the spread. You want to try to discourage scratching, which is hard if it's a 3-year-old. Washing of clothes and bedding should kill the pinworm eggs. Again, this is going to be the most common one you're going to see in clinic. Differential, tinea, hemorrhoids, contact dermatitis, strongyloidiasis, which is another roundworm that causes sporadic rash or itching, anal fissures, several other things there. This is a chart just for chart people, if you want to look at the different types of treatments for different types of worms. That is not all inclusive, but there are several there for you. We'll start malaria, and then we'll probably stop in between. So malaria is caused by Plasmodium species, which are spread by vectors such as mosquitoes. Malaria is the most important parasitic disease in humans because it causes hundreds of millions of illnesses and nearly 1 million deaths a year. Hundreds of millions and 1 million deaths per year. The disease is endemic in most of the tropics. There are 95 countries and territories that have ongoing transmission. South Central America, Asia, Africa, Middle East, Indian subcontinent, Southeast Asia, Oceania. The continent of Africa probably has the most transmission, the most morbidity and mortality and deaths in young children. That's why the asterisk is next to Africa. There are about 2,000 cases of malaria diagnosed in the U.S. per year, almost all of which are imported for travel. So why do we need to ask that travel history? It is super important. Any patient that comes in with fever, chills, recent travel, and an unspecified illness, you're gonna have to really turn on your thinking cap. A travel history. There are hundreds of species of Plasmodium. We're gonna talk about 4: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae. The falciparum species is responsible for the most severe cases and the most deadly of the 4. It is predominant in Africa. Children, pregnant women, travelers are all high risk for this falciparum. Vivax is pretty common too, but it's not as severe as falciparum. Ovale and malariae are usually not associated with severe disease, and they're less common. So falciparum and vivax are probably going to be your most common, but falciparum is the most deadly. Malaria is transmitted by the bite of an infected female Anopheles mosquito. During the feeding, it injects sporozoites, which is a parasite. These sporozoites circulate the liver and infect hepatocytes, so it's gonna affect the liver cells. This part of the life cycle is asymptomatic. The sporozoites then mature into hepatic schizonts. The schizonts rupture and release something called a merozoite, which are released from the liver and infect the blood cells, the erythrocytes. This is what causes human disease or symptomatic illness. You will have several rounds of this, which continues to circulate this parasite, yes.
You say what the merozoite?
The merozoite is when the hepatic schizont ruptures, and it then will release those little parasites. Or whatever you call it. An uninfected mosquito comes and bites the infected person, and then it goes and infects someone else. So that's how the cycle continues. From the initial bite to when the sporozoite invades the liver cells, the hepatocytes, and the cell ruptures and releases is about 6 to 90 days. Incubation may vary among species, but Falciparum is faster, it has a shorter incubation. Mother to infant blood transmission is uncommon. This is just a picture, so you see that bite from the infected mosquito. Travels to the liver where they lie dormant for about 10 days to a month. Then the parasites leave the liver, infect the red blood cells, and this is when malaria signs and symptoms start to develop. The malaria is transmitted to an uninfected mosquito. When it bites someone with the disease, that mosquito can then spread malaria to other humans. Patients with sickle cell and thalassemia seem to have some resistance or some protective barrier against malaria. There was some reports about G6PD, but that has a lot of controversy, so we won't even talk about that. But sickle cell and thalassemia have been shown to have that. Signs and symptoms. An acute attack of malaria typically begins with a prodrome of headache and fatigue, followed by fever. So headache, fatigue, followed by fever. So they'll have shake and chill, then they'll have a fever, and then they'll have night sweats. That is the classic presentation. Chills, high fever, sweats. Chills, high fever, sweats. Classic presentation. The fevers are typically cyclic, and patients can do well in between the episodes. In early stages, fevers are intermittent. Without treatment, they can become more regular. General symptoms can additionally include headache, which they've already had, malaise, myalgia, dry cough, abdominal pain, nausea, vomiting, and diarrhea. Some patients may present with seizures or febrile convulsions. And because they're chronically infecting the red blood cells over and over and over, you may have anemia, you may have splenomegaly, mild hepatomegaly, patients may have jaundice. Rash, lymphadenopathy, not typical in malaria. Not typical in malaria.
They're having seizures. How high do these fevers get?
I'm not for sure, I'll have to look at it.
I can.
This is just a picture you can kind of use. It is imperative that anyone that has suggested symptoms, any of these, that has a fever and has recently traveled, be evaluated for malaria. The risk of the falciparum is usually greatest within 2 months of travel. Falciparum, 2 months of travel. The other varieties can be weeks to maybe almost close to a year. Falciparum is the one we're going to talk about, is the worst. So, with falciparum, this one causes the severe illness. It has a high parasite load. And it can cause dysfunction in any organ system. Neurologic abnormalities include repeated seizures, psychosis, agitation, and coma. Coma is the hallmark in cerebral malaria. These patients may also have severe anemia, hypotension, acute respiratory distress syndrome, retinal hemorrhages, acute kidney injury, hypoglycemia, disseminated intravascular coagulation, and metabolic acidosis, as well as other things. This is the worst because of those results and outcomes. To confirm your diagnosis, you want to do a Giemsa stain, blood smear. That's the mainstay of diagnosis. A Giemsa stain, blood smear. Giemsa stain, blood smear. Giemsa stain, blood smear. Giemsa stain, blood smear. This is gonna help you confirm your diagnosis. You can also identify by looking for plasmoidal antigens with a dipstick. Serological tests may indicate a history, but are not good for acute infection. They can tell you if there's a history of infection, sort of like that EBV, IgM, IgG antibody test, but it can't tell you about an acute infection, only a history. And I believe that they said the antibodies can persist up to 10 years. So that can tell you about history, but not acute. So remember, Giemsa stain, blood smear for this. In non-falciparum species, the first line of treatment is going to be chloroquine. Chloroquine, 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 for anything that is not falciparum. For P. vivax and P. ovale, you may add primaquine to your chloroquine. And who do we have to be careful giving antimalarials to? G6PD deficiency. It can cause hemolytic anemia. So you always want to screen for G6PD deficiency before you start any antimalarials. So for falciparum, the World Health Organization recommends artemisinin-based combination therapies, which I'm not sure if you guys talked about that. And then Dr. Noel. The treatment is going to be Poretum, Malaron, quinine sulfate plus doxy or tetracycline. It is not chloroquine. We have 6 different types of regimens. This is listed in your book, all the different ones. Those are just 3 of the more common. P. falciparum is resistant to chloroquine. It is resistant to chloroquine. Hospitalization may be required for non-immune patients. Severe malaria is a medical emergency. They have any signs of severe malaria, any of those dysfunctions of those big organ systems, you want to treat with IV artesunate. You will need approval from the CDC to use that. It is not commonly in stock. So if you have to order it or get it, you're going to need to probably start your antimalarials first while you're waiting on it. If you have travel, maybe you're working in another country, you might be able to use IV quinine, but that is not available in the US. They also want to start IV fluids, work on maintaining their electrolytes and supportive care, respiratory support, whatever else that patient might need. With timely treatment and no complications, fevers typically resolve in a day or 2. Mortality is 0.1%. Severe malaria can progress to death, but most respond to treatment. And you're going to refer. Any suspected case of malaria, you need to get in touch with ID or travel medicine specialists. Again, remember, your referral should not delay initial diagnosis and therapy. Oh, I can't get in touch with anybody. you need to go ahead and start treating. Or try, do your best. With any oral antimalarials if you can't get the artemisinin. Or the IV therapy for the severe case. Prevention. This is pretty much based on travel, because like you said, 2,000 here a year, but those are imported. So for patients who are traveling or for yourself, you want to avoid outdoor exposure between dusk and dawn. Those Anopheles mosquitoes feed. Wearing clothing that decreases the amount of exposure. Wear effective insect repellent, deep. Sleep in a bed with nets treated with insecticide. Stay in a well-screened or air-conditioned room. For pregnancy, they may offer sulfadoxine promethamine once during the second and third trimesters to improve outcomes in those who live in those endemic areas. And then there's chemoprophylaxis. Travelers from non-endemic regions going to an endemic region might use. When I went to Swaziland, I don't believe I was given anything because I was in a low-risk area. But they do offer treatments when you see travel specialists before you go abroad, especially to work like that. I think I got something for cholera, for sure. So, let's take a break and then we'll start with toxoplasmosis. We'll come back at 9:20. There are estimated 400 to 4,000 congenital infections that occur annually. Let's get into it. So toxoplasmosis is an infection found worldwide caused by the intracellular protozoan parasite Toxoplasma gondii. This occurs in humans and in many species of mammals and birds. The definitive hosts are cats. So we talked about intermediate host and definitive host, intermediate being the egg and the larvae, the definitive when that grows into an adult. So the definitive hosts are cats. Humans are infected after ingestion of cysts in raw or undercooked food or ingestion of oocytes in food or water contaminated by cats. You'll see a picture there with the life cycle of the parasite, transplacental transmission of tachyzoites and trophozoites, which are basically what the oocytes and the cysts turn into after ingestion. Those can be transmitted through the blood transfusions or organ transplant. So like we said, you probably talked about this in peds, maybe with your torch infection, so you hopefully are familiar with it. The high-risk groups we're thinking about in Clin Med would be your pregnant women, feline owners, people who own 3 or more cats, immunocompromised. For those patients, it can be deadly, especially in our HIV and AIDS patients. Those that ingest undercooked meat, particularly in Nepal, Europe, and the US. Deer hunters who eat undercooked deer meat, and unpasteurized goat milk, patients that drink the pasteurized goat's milk, they are at higher risk. After ingestion of T. gondii, the infection progresses from the GI tract to the lymphatics and then it disseminates. Most of the infections are asymptomatic. About 10 to 20% are symptomatic after an incubation period of a week or 2. After initial infection, even if asymptomatic, latent infection will persist for the life of the host. So once you have it, it's there. This can be reactivated in immunocompromised patients, so our HIV patients, cancer patients, and those on immunosuppression therapy. Patients with an infection caused by T. gondii typically present with mild febrile illness that resembles infectious mononucleosis. And what are 2 other viruses we talked about that can cause infectious mononucleosis? DMV and EBV, and which is the most common for infectious mono of those 2? EBV, yeah. So this is another one that can go on your differential. 1% of cases of mono are due to toxoplasmosis, so it's gonna be low on your list. Patients will present with a non-tender cervical or diffuse lymphadenopathy that can persist for weeks to months. It is non-tender, because there's another cat disease, cat scratch, Bartonella, that is tender lymph nodes. Non-tender for toxoplasmosis, tender for Bartonella cat scratch. Other systemic findings may include fever, malaise, headache, myalgia, sore throat, rash, hepatosplenomegaly. You see what I've highlighted there? Those are gonna be your most common.
Bless you.
Severe manifestations are rare, but include pneumonitis, meningoencephalitis, hepatitis, myocarditis, retinochoroiditis. We'll briefly talk about congenital infection. Fetal infection follows maternal infection in 30 to 50% of cases. But the risk varies by trimester, with the third being the highest risk. Third trimester is the highest risk, so if you have a pregnant patient, they are at highest risk in the third trimester. These early fetal infections can lead to spontaneous abortions, stillbirths, and severe neonatal disease, including neurologic manifestations.
Is it late infection, like transmit? Between this, like this is supposed to be like late infection for the entire life. So it's like they got it before, and then it's like.
Let me double check that. I would think more of the acute, but because usually the late, we typically only see in the immunocompromised patients, but. Immunocompromised pregnant person, you can always consider that as part of the, something you should be thinking about, for sure, because that could be reactivated. Retinochoroiditis is the inflammation of the retina and the choroid that may present after congenital infection. This is the most common late presentation of congenital toxoplasmosis. It is seen commonly in teens or young adults. And this ophthalmic exam looks a lot different than our scrambled eggs with ketchup pizza pie. You will see a fluffy white retinitis with a scar next to it. My clicker isn't working because I'm having to do this different today, but you can see the black necrotized areas and scarring as well. On that exam, patients may also present with uveitis, so they may have pain, photophobia, visual changes, usually without other systemic symptoms. I have marked on here, headlight in the fog. Sometimes they describe that ophthalmic exam as a headlight in the fog. I don't know if that looks like text, but that may be something that you may see it described as. These signs and symptoms eventually improve, but visual defects can exist or can persist. Rarely results in glaucoma and blindness. In our immunocompromised patients, reactivation is common, or it's one of the bad defining illnesses. Most common manifestation in patients with AIDS is encephalitis with multiple necrotizing brain lesions. So you'll see like a ring enhancement around that photo of the CT scan or MRI. CT. These patients may present subacutely with fever, headache, altered mental status, focal neurologic findings, and other evidence of brain lesions, less commonly chorioretinitis and pneumonitis. Chorioretinitis is a little bit different because it's not both layers. The retinochoroiditis from the first one is both the retina and the choroid. The chorioretinitis is usually inflammation in either or both of those layers. where the retinal is bold for sure. Toxoplasmosis in a seronegative recipient of a solid organ or bone marrow transplant is almost always due to reactivation, rarely transmission of infection. But those patients are also at risk. How do we test? ELISA testing is going to be your most commonly used. In most patients with suspected reactivation disease, the serum IgM antibodies are usually absent because they appear in the early stage, where IgG is the late stage. So in an acute infection, IgM antibodies usually appear within a week and continue to rise. So you'll see that in the early. In the IgG, that usually follows about 2 weeks after the primary infection and peaks about 8 weeks and persists for life. So similar to when we were talking about history of versus acute. For reactivation, your immunocompromised patients are probably not going to have IgM antibodies. In a patient with signs and symptoms of reactivation, you could do additional testing like a PCR or histopathology. Not going to talk about those in detail, but I did leave some resources about those tests. Might do a CT or MRI for imaging. Needed. Treatment, generally not necessary. In an immunocompetent patient, it's self-limited. However, if you do have to treat promethamine, plus sulfadiazine with polinic acid. Promethamine plus sulfadiazine with polinic acid. That is your combination in toxoplasmosis. Primary infection symptoms may fluctuate, but symptoms again typically recover, self-limited within a few months. Prevention is going to center on the avoidance of undercooked meat or contact with material contaminated by cat feces, particularly in our seronegative pregnant women and our immunocompromised persons, because they are at the highest risk. So they definitely, you want to talk to them about avoiding those types of foods that, and basically cleanliness, to avoid getting that cat feces in their food and drink. Thorough cleaning of hands and surfaces is needed after contact with raw meat and areas contaminated by cats. Oocytes passing cat feces can remain inactive for a year or more, but fresh oocytes are not infected for 48 hours. Litter boxes should be changed daily, if possible, especially in those high-risk patients. And for the immunocompromised individuals, chemoprophylaxis might help prevent primary or reactivated infection. One of those drugs used in the prophylaxis for those patients is Bactrim. The differential includes all of those infectious viruses we talked about. Bartonellas, that cat scratch, remember you're gonna differentiate that from non-tender to tender. Also with toxoplasmosis, the lymph node looks red. You may have like overlying red skin, which will help you kind of differentiate between those as well. And then there's some non-infectious and autoimmune causes that may be very similar. We talked about scabies, so we're going to get into our other parasites, and then we'll start going into some of our other sections. So scabies is caused by Sarcoptes scabiei. It is usually acquired through the bedding of an infected individual or by other close contact. Usually found in areas of crowding. For a patient to get scabies from another person, it needs to be a prolonged direct contact. It can't just be in passing, oh, you gave me scabies when I walk past you, it's not like that. They have to be, in direct and prolonged contact. We see this in facility associated scabies in our long-term care facilities. With scabies, the itching, signs and symptoms, there's itching, which is usually generalized, severe, and worse at night. Infestation usually spares the head of the neck, which might help you differentiate it from other conditions. You may find burrows, which I highlighted, vesicles and pustules. Burrows are very common, especially on the finger webs and in wrist crease. Mites, ova, and brown dots of feces can be visible microscopically. Red papules or nodules on the scrotum and on the penile glands and shaft are pathognomonic. First time I saw scabies was in my peds rotation. And the patient had what looked like an in and out bump, like one bump right next to each other, and it was right in the web. So definitely something you might see. Sometimes they describe it as knots on a rope because the bumps are right in a line with each other. Are you gonna test for this? Diagnosis is confirmed by microscopic demonstration. You would use a 15 blade and scrape each lesion until it's flat. We never confirmed, and we just treated it. Patients with crusted or hyperkeratotic scabies must be evaluated for immunosuppression. If no iatrogenic cause of immunosuppression is present. So if they're presenting with crusted scabies, they need to be tested for HIV. If there's no other cause of immunosuppression. This slide was confusing, so I changed it this morning, so yours is gonna look a little bit different. My apologies. So we're gonna treat the mites and try to control the dermatitis. You can use a mid-potency topical corticosteroid like triamcinolone or antihistamines to help with itching, but your treatment of choice is permethrin. And you're gonna use this from the neck to the toes, usually overnight, wash it off in the morning, and then repeat that in 1 week. Permethrin, treatment of choice in scabies. Overnight treatment, wash it off in the morning, repeat it in a week. Even after you've eradicated the mites, the dermatitis can last for months. If there's widespread infection, you might need to treat the patient with ivermectin. But remember, permethrin for scabies, alternative ivermectin if widespread.
So we do need to scrape it for diagnosis.
That's how you would confirm microscopic. You would scrape it with a 15 blade until it's flat, getting the cells off of it, and then send it for testing. I'm just saying, we didn't to do that, but yeah, it looks like, I mean, it's pretty, if you see the in and out and the webbing and the scratching, and then grandpa has it too, grandma has it, they live with their grandparents, then more than likely it's scabies, and you probably are safe to go ahead and initiate some treatment. Of course, if you got your diagnosis back and it wasn't, you need to switch your therapy. But it's topical and it's probably not gonna cause a lot of systemic symptoms. But that would be how you test it. Everybody have a chance to look at that a little bit. My apologies again for that. Treatment, bedding, and clothing should be laundered. Set aside for 14 days in plastic bags, almost like they do with bed bugs. High heat will kill the mites and the ova. And you need to treat everyone in the house or in the institutionalized group if they're all in one setting together, if there's like a group home or whatever, they all need to be treated. Another one you're familiar with, trichomoniasis vaginalis. This is a protozoal flagellate, often infecting the vagina, skin ducts, lower urinary tract in women, and lower genital urinary tract in men, most often sexually transmitted. One of our most common sexually transmitted diseases, affecting about 3.7 million in the US. So signs and symptoms, often asymptomatic. Patients may have a copious, frothy, yellow-green, malodorous discharge. Other symptoms may be vulvovaginal discomfort, pruritus, dysuria, increased frequency, dyspareunia, lower abdominal pain. Diffuse vaginal erythema and red macule lesions on the cervix. That strawberry cervix shown. Remember how to test that? Wet mounts and neck testing. So standard is neck testing. The pH is typically 4.5, over 4.5 in infections due to trichomonas, that's a type of, and bacterial vaginosis. Treatment of both partners is recommended with metronidazole and sinadazole. Questions about trichomoniasis? Easy breezy. All right, Chagas. Chagas disease, named after a Brazilian physician, Carlos Chagas, in 1909, also referred to as the American trypanosomiasis or Chagas disease. Estimated 6 to 8 million people are infected with Chagas disease, mostly in rural areas, with the highest prevalence in Bolivia, Argentina, Paraguay, Ecuador, El Salvador, and Guatemala. The CDC estimates that more than 3,000 people have trypanosoma cruzi infections here in the United States. Most people with Chagas disease in the United States were infected in parts of Latin America, where it's found. So that's the little vector, the bug that causes it, called the kissing bug. It is caused by a parasite, Trypanosoma cruzi, which is transmitted to animals and people by insect vectors found only in the Americas, mainly in rural areas of Latin America where there's high poverty. Transmission is by blood transfusion, organ transplant, congenital transfer, and contaminated food. Often acquired in childhood. In many countries in South America, Chagas disease is the most important cause of heart failure and death. So this might affect your Latin American immigrants that you're going to be taking care of. This is the life cycle. The infection is transmitted by triatomine bugs or kissing bugs, which are infected by ingesting blood from animals or humans who have the circulating trypanosomes. Multiplication occurs in the digestive tract of the bug, and infected forms are eliminated in feces. So essentially, this bug, they call it the kissing bug because it likes to lay in places close to your mouth, lips, face, eyes, somewhere that's unexposed, that's not covered by clothes. They like to bite at nighttime, so think of a sleeping patient. The bug lands, bites, it puts its little, can't even think what it's called now, it has a special name for its little hook, and it infects. Patient scratches, knocks it off, rubs it, lets those little parasites into that little bite. The bug, actually, after the bug bites, it poops. So that poop is what's going into the scab, or not the scab, but the scratch. And you scratch that in, and now that's entering your bloodstream, essentially. Infection in humans occurs when the parasite penetrates the skin through the bite wound, mucous membranes, or conjunctiva, so it can affect your eye as well. That's that picture. You can use that to kind of help you understand a little bit more. 70% are asymptomatic. The acute phase usually seen in children and lasts about 1 to 2 months. Earliest signs are at the site of inoculation. The eye is called a Romano sign, which you're gonna see on the next picture. This is a unilateral edema, conjunctivitis, and lymphadenopathy. Or you might see a shigoma, which is swelling in the area of the bite with local lymphadenopathy. Additionally, these patients may have your common fever, malaise, headache, anorexia, generalized lymphadenopathy noted, mild hepatosplenomegaly. Rarely myocarditis and meningoencephalitis. So let's take a look at those signs. There's your Romano sign with the unilateral edema. Likely has lymphadenopathy as well, and the shigoma right there at the bite. They may also have the lymphadenopathy. That's the acute phase. There is a latent period and a chronic period. The latent is usually asymptomatic and can last for a lifetime. 10 to 30% become symptomatic years after the infection. So not a big group, but it's possible. Chronic Chagas disease can cause cardiac disease like arrhythmias, heart failure, embolic disease. There can be smooth muscle abnormalities that lead to megaesophagus and megacolon, as well as dysphagia. Immunosuppressed patients may have brain abscess or meningoencephalitis. In immunosuppressed patients, late Chagas can reactivate. And that's typically, when you would see those brain abscess and meningoencephalitis. We test this by detecting the parasite, using another nemesis stain. If you live in that endemic area. So with an acute infection, evaluation of fresh blood or buffy coats may show motile, trypanosomes, and fixed preparations may show gum-sustained parasites. So you're gonna do blood screening for that. Trypanosomes may be identified in lymph nodes, bone marrow, pericardial, or spinal fluid. There are also molecular tests that are highly sensitive. And in chronic Chagas disease, it's usually diagnosed serologically. Those are more just to know, not anything. I think you should really focus on, just remember that blood smear for your initial testing. Treatment is inadequate because of the 2 drugs used. Benzodazole and nifurtimox. I don't even know how to say that. Nifurtimox, never use that one. These can cause severe side effects, and they have to be used for long periods of time. In acute and congenital infections, the drugs can reduce the duration and severity, but cure is achieved in only about 70% of patients. For chronic patients, you just need to manage the sequelae of the infection. So not the easiest to treat. Gonna probably consult ID anyway at this point. Zika was an add-on. Zika virus was discovered over 70 years ago. There were 2 major outbreaks in 2007 and 2015, with over 200,000 cases reported in Brazil in that 3-year breakout in 2015. Zika virus is the RNA flavivirus. It is similar to viruses that cause dengue, fever, yellow fever, and West Nile virus. It is transmitted primarily by the Aedes species mosquito found throughout the Americas. Who's at risk? Patients who are pregnant or plan to become pregnant. Majority of people are asymptomatic, up to 80%, or they have very mild symptoms. The remaining 20% that do have symptoms may have acute onset fever, pruritic maculopapular rash, non-purulent conjunctivitis and arthralgias that last about 7 days. Complications or birth defects if mom gets infected. This can cause congenital Zika syndrome, which is often associated with microcephaly. You'll see in that picture in the top, little baby has a smaller head. Pregnant patients can also experience stillbirths and miscarriage, as well as Guillain-Barré syndrome. They say 2 out of 3, two or 3 out of 10,000 have Zika virus that are diagnosed with Guillain-Barré. It's not a big group.
The mother gets Guillain-Barré or the baby?
The mother. Diagnosis, NAT testing. NAT testing, you can also do IgM antibodies, but NAT testing is probably gonna be your tougher choice. Treatment is supportive. There are no antivirals for the treatment of Zika, no approved vaccines against Zika, not yet, at least. Prevention, environmental control of the mosquitoes and removal of areas where standing water is stagnant. Need to use repellents for the mosquitoes, stay in air conditioned or screened in areas when possible if traveling to those endemic areas or an area where there's a Zika outbreak. We have not seen Zika here since 2015. I believe the first one was 2015. The last cases were in Florida, and that was like over 7 years ago. Mainly largely in US territories like Puerto Rico. But I believe the last about 7 years ago, there were 200 plus in Florida and maybe 6 out of Texas. Giardiasis caused by Giardia is going to be the next one we talk about. Giardiasis is the most common intestinal protozoan pathogen in the US. The most common intestinal protozoan pathogen in the US and Europe for that fact. Giardiasis is caused by a flagellate, Giardia lamblia. It's found worldwide, usually in areas where there's poor sanitation. Most commonly seen in children. In the US, at-risk groups are those who drink contaminated water during recreational or wilderness travel. Just like the guy on our picture there. On a hike, drink some water. This includes swimming, hiking, camping. Also, men who have sex with men and the immunocompromised are also at a higher risk. This is probably the most commonly reported parasitic illness in the US. Transmission, fecal contamination of water and food, person-to-person contact, and oral sexual contact. Signs and symptoms are listed. 50% with no discernible infection. Others have acute diarrhea. I have bolded what you need to know: profuse and watery, greasy, malodorous, rotten egg stool. Bing, 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 bing. Profuse, watery, greasy, malodorous, rotten egg stool. You need to be thinking about Giardia. These patients may also have abdominal pain and cramps, distension, flatulence, fever, and fatigue, and malaise. This stool does not usually contain blood, pus, or mucus. So the things we've talked about so far, we talked about 2 other conditions that have watery, profuse diarrhea. If that was the only information you had, what are some things you should be thinking about? Cholera, and there was one more, that if you have 3 or more stools in a 24-hour period, together, yeah, should be thinking about those until you get more information. Our lab test diagnosis is going to be made by identification of trophozoites or cysts in the stool. Again, the stool generally will not have blood or leukocytes, white blood cells plus mucus. A wet mound of liquid stool may identify motile trophozoites. Stain thick specimens may show the cysts or the trophozoites. Sensitivity of the stool analysis is not ideal. Only 50 to 8% for a single specimen, so you need to test it 3 times to get that 90% sensitivity. Again, diagnosis, remember, is stool sample. How are you gonna treat it? Tinidazole or metronidazole. Tinidazole has the advantage of being a single dose therapy, where the metronidazole you have to do 3 times a day for 5 to 7 days. Cure rate in a single course is about 80 to 95%, so not too bad. Some of the side effects of those medications are listed. Albendazole is an alternative. Will have similar efficacy and possibly fewer side effects, but for testing purposes, you should remember tinidazole or metronidazole. Tinidazole is going to be just like metronidazole, so you need to tell those patients to avoid drinking what?
Alcohol.
Yeah, differential listed there. And you can click on those if you want to. I try to use Medscape so you can click and read about the disease if you need it. Some of them are applicable, some are not. And then we'll do our mycobacterial diseases. We've already talked about TB, so we're not going to talk about that, but we are going to cover MAC, Mycobacterium avium complex, which is caused by Mycobacterium avium or Mycobacterium intracellularly. It is an aerobic, ubiquitous parasite or bug found in soil and water. It is not communicable from person to person. It is not communicable from person to person compared to what? TB, which is. Okay, so it's gonna help you differentiate. It is thought to be acquired through inhalation, thought to be, so there's still some questions out about that. Non-tuberculous mycobacterial infections are among the most common opportunistic infection in HIV and AIDS patients. It is rarely seen in the immunocompetent patients. It can be associated with patients who have chronic lung disease. So when we think about mycobacterium, basically the bacteria, the organism adheres to the cells in the respiratory tract and the immune system responds, sending the macrophages to destroy the bug. But the outer layer has like a lipid protective coat that makes it hard for it to get destroyed. So it goes inside the macrophage, and the macrophage essentially isn't able to destroy it, and it continues to multiply inside, causing more inflammation. More macrophages are coming. So it just is this constant cycle. That's why you might see it more in a person with a weakened immune system, because their immune system is already shot. Chronic lung disease. You might see in these patients with underlying COPD, cystic fibrosis, bronchiectasis. This version of MAC is common in white, middle-aged, older men with a history of smoking and COPD. So we have our immunocompromised patients, and then we have our patients with COPD, cystic fibrosis. In general, more patients that present with MAC are white, older men who have a history of smoking and COPD. It says non-smoking, tall, thin women over 50 with bronchiectasis on chest X-ray. They can also present with MAC. This one is not really well studied, but the patients typically in that case experience these respiratory symptoms for years and years and years and years. They find this bronchiectasis and they don't really know where it's coming from, but eventually MAC is what is found. In some cases, it's a very few patients I was looking at a study about. It's also in up to date if you want to look at it there. MAC is aerobic, so it likes to hang out in the lungs that have a lot of oxygen. It can move to the lymphatics and spread to the liver, spleen, and bone marrow. It may cause lymphadenitis, which is primarily seen in children. Here you have an 8-year-old with a full beard. So everything is not gonna be textbook. He's not 8. But yeah, that's lymphadenitis in a MAC patient. So it's not always children, but primarily it is children. Disseminated disease we see in our AIDS patients with a CD4 count under 50. And what do we say AIDS is? And that CD4 count drops below what number?
200.
200. So 50 is very low. So if you see MAC, those patients are really sick. It is often resistant to standard anti-tuberculous drugs. So if you're thinking patients presenting with symptoms similar to TB, you treated them, but they're not getting better, you need to be thinking about MAC. Typical presentation, persistent cough, which can be productive or dry. Usually no fever, and then some of your symptoms that we see with our TB patients, fatigue, sometimes weight loss, night sweat, dyspnea, occasional hemoptysis. These patients tend to have recurrent infections. Duration of cough was 25 weeks before the diagnosis was made in a lot of these patients. 25 weeks of cough. But some patients are symptomatic for years prior to diagnosis. So it can sound pretty TB-ish. Your history is going to be important. You need to definitely ask the right questions to try to narrow that down. Diagnosis, sputum culture, imaging studies. Because patients might have 25 weeks before they're even, before they're worked up correctly, lung destruction may be quite extensive on imaging studies. You might see nodular, bronchiectic, or fibrocavitary findings on the images. Treatment depends on the pulmonary, if it's pulmonary, skin, or soft tissue, or disseminated, usually treated with a 3-drug regimen. First line includes macrolides, clarithromycin or azithromycin, plus rifampin or rifabutin, plus famotidine. Do you remember what color the urine is with rifampin?
Orange.
For the lymphadenitis, some patients might need surgical excision, especially if it looks like that starting picture. Here is a CT scan and an X-ray of a non-smoking female with MAC. You can see the density in the right middle lobe. Nodules in the lower lobe on the high resolution CT. Differentials. So let's take another break and then we will start with our spirochetal diseases. Lyme disease, Rocky Mountain spotted fever, and then we will wrap this thing up. So we'll do 10 minutes, 10 up to 12.
You said pause.
10, 16, we'll start back.
By the end of this semester.
Oh, sorry, I couldn't hear you.
Most tick bites are harmless and don't need any medical treatment, but some ticks can have harmful germs that cause Lyme disease, Rocky Mountain spotted fever, the two we're gonna talk about today. A deer tick is super tiny, probably about the size of a poppy seed. So you can often miss those. There are about 100 species of ticks. Gonna look first at Borrelia. So Lyme disease, the most common vector-borne disease in the United States. Lyme disease is the most common vector-borne disease in the United States. It is caused by a gram-negative spiral-shaped bacterium or a spirochete called Borrelia burgdorferi. It is transmitted to humans through the bite of infected black-legged ticks. Ixodes ticks are another name for those, which is usually a very small tick. Because of its size, the bite usually is painless and goes unnoticed. And 75% of patients don't even know they were bitten. Here's a map. I'm giving you two links. Where we see reported cases of Lyme. This map is from 2019. Maryland is one of 12 states where the majority of all Lyme disease cases occur. 20 to 30% of deer ticks in Maryland carry Lyme. 20 to 30% in Maryland carry Lyme. The counties with the highest in a 20-year span, number one, Montgomery County, followed by Howard County, with Anne Arundel coming in third. The highest cases of Lyme in the 20-year range. I think the highest, Montgomery was maybe like 2,600 on that tick checker. We're in Montgomery County, can't tell you that. So, general considerations, I've given you basically like a general synopsis, but then we're gonna go into each stage of Lyme disease. So typical symptoms include fever, headache, characteristic skin rash called erythema migraines. Characteristic skin rash, you see it on the picture, this is classic. For Lyme disease, if left untreated, the infection can spread to joints, the heart, and the nervous system. Diagnosis is usually based on symptoms. Physical findings. The rash is the big one. This is an extending rash. So you'll see a reddened area in the center where the tick bite occurred. And then over several days that will increase in size, spreading out, it's extending, so it's extending out. And then it develops this ring around the outside, giving it a bull's eye appearance, bull's eye rash. So it's circular, kind of like erythema migrainatum, which we talked about. But migrainatum is clear in the center, where this one is red in the center. If you need to differentiate, now this one can present in different ways, but basic findings, you need to look for a bullseye rash appearance. Those other ones are outliers. Lab testing is helpful if used correctly and performed with validated methods, we'll talk about. Other considerations, most cases of Lyme can be treated successfully with a few weeks of antibiotics. Steps to prevent Lyme disease include insect repellent, removing ticks promptly, applying pesticides, and reducing tick habitat. The ticks that transmit Lyme can occasionally transmit other tick-borne diseases as well. In most cases, the tick must be attached for 36 to 48 hours or more before the Lyme disease bacterium can be transmitted. So it has to be on there for at least a day and a half or 2 days. The incidence of disease is significantly higher when the tick is attached longer than 3 days, 72 hours, and it's engorged full of blood. Incidence of disease is significantly higher when the tick is attached for longer than 72 hours. So you're gonna have more symptoms, more illness in those cases. So we're gonna break down each stage. There are 3 stages of Lyme disease based on early or late manifestations and whether or not the disease is local or disseminated. There can be some overlap between CNS findings and musculoskeletal skin findings, things like that. The first stage is early localized infection. Again, most patients are gonna have that classic lesion that progresses. So an extending lesion with a bull's eye appearance. It is flat or slightly raised at the bite site for about a week. Flat or I'm sorry, I can't read. Flat or slightly raised red lesion at the bite site about a week after the tick bite. The average is about 7 to 10 days. But you can see that range is wide, 3 days to a month. Common areas are in areas of tight clothing, the groin, the thigh, axilla. Again, we said that lesion expands over several days. About 10 to 25% of patients do not have the typical rash. 10 to 25% do not have the typical rash. And up to 20% have more than one. They'll have multiple lesions. So again, those are outliers. Concomitant viral or flu-like illness develops in most patients. They may have myalgias, arthralgias, headache, fatigue. Fever may or may not be present. But if you have a patient with a rash that looks like a bullseye, achy joints and a headache, you need to be thinking about Lyme. These are the outliers I was speaking about. You can have blistering lesions, a uniformly red lesion, blue-red lesion outside of that bullseye. And I gave you a link, which you can click on later, which I think may help you. It shows you the varieties of the erythema migrans, but it also has a second tab, which is lookalikes. So it'll show you different things that may look like erythema migrans to help you in determining differentials. The second stage is our early disseminated infection, which can occur weeks to months later after the bite. Up to 50 to 60% of these patients are bacteremic. They have some type of viable bacteria in their blood. Within days to weeks, they may develop secondary skin lesions in about half, 50%. These lesions are similar to the primary lesion, but usually smaller. And then rarely at the bottom picture, you'll see a cutaneous hypopigmented skin lesion called a borrelial lymphocytoma. This is rare, not a must-know fact. Bullseye, bullseye, bullseye. But you need to look at it for sure. Malaise, fatigue, fever, headache, sometimes severe neck pain, and generalized achiness are common with skin lesions. These can be transient symptoms, intermittent. Less likely cardiac manifestations and neurologic manifestations. The cardiac manifestations, you need to know that it can cause a pericarditis with atrial or ventricular arrhythmia and heart block. Neurologic manifestations, you may see aseptic meningitis, mild headache, and neck stiffness. These patients may also present with cranial nerve 7 neuropathy. Do we remember what cranial nerve 7 is? Face. Well, to touch. We all see this. All right, so facial palsy, usually unilateral. And you'll see the picture there at the top. These are more rare, much less common manifestations in that second stage. Not gonna read them, I don't want you to memorize it, but you can read over that. Conjunctivitis, panophthalmitis, those discolorations of the eye, less common, or even rare. In stage 3, our late persistent infection. This can occur months to years later. Musculoskeletal manifestations in up to 60% in early reports. That is down now. But in early reports, musculoskeletal manifestations were reported in about 60% of patients. I believe it's down to like 10 to 20%. The classic manifestation of this late disease is a monoarticular or oligoarticular arthritis of the knee or another large weight-bearing joint. This is usually self-limited. Chronic arthritis can develop in about 10% of those patients. You'll see the picture there. That joint is very swollen, but usually less painful compared to maybe a bacterial septic arthritis. So that may help you differentiate. It may hurt a little, but it's not as painful. So those might be two things in your differential. The patient comes with, swelling of the joint joint. Neurologic manifestations are rare. Some patients may experience subacute encephalopathy, which might present as memory loss, mood changes, and sleep disturbance. Neurologic changes can also cause other issues like vertigo and dizziness. That's the only time I tested patients for Lyme, was for vertigo patients where we could not figure out any other cause for their vertigo. After they saw ENT and neuro and other specialists, and we may do Lyme titers to try and see if that may be what's causing it, maybe some neurologic manifestation. These are a few other things, again, rare, not really common, just additional information. Patients in this third stage may have intermittent paresthesias, stocking glove distribution. They may have ACA, acrodermatitis chronica atropicans. This is unusual, like fibrosing skin. It's like a blue-red color. That can happen up to 10 years later. Looks like scleroderma. Again, those you don't have to ever. Your differential, other tick bites in there, the Lone Star tick, Rocky Mountain spotted fever, which we're gonna talk about, and other things. So how do we confirm? Diagnostic procedures. A person who has been exposed to a potential tick habitat within 30 days, just prior to developing erythema migrans, with the following, fulfills the diagnosis criteria for Lyme. So if they were in a tick habitat, potential tick habitat, camping in, we're just in Montgomery County, where you want to know about, and they come in with erythema migraine. It is diagnostic. If you are able to diagnose the erythema migraines, they have at least one late manifestation of the disease and laboratory confirmation. How do we test it? The test is done by detection of specific antibodies to the Burkhardt-Dorfrey in serum by ELISA or IFA testing. A two-test approach is recommended, similar to what we did in HIV patients. So you're gonna test them with the ELISA. If it comes back positive, then you need to confirm it. We said we don't use Western immunoblot in HIV, but they do use it in Lyme, which detects for both IgM and IgG antibodies. Some of these patients may also have an elevated SID rate. Liver biochemical tests may be abnormal, mild anemia, leukocytosis, microscopic hematuria, and a low percentage. It is said that 50% of patients with early disease can be antibody negative for the first few weeks. So you can make the diagnosis based on clinical findings. If they don't have any antibodies, nothing's gonna show up on that lab confirmation. But if you see erythema migraines, they've been in a tick habitat, maybe they're achy, tired, whatever, headache, you can treat it as Lyme. Other testing, PCR testing, just very specific for detecting Borrelia DNA, CSF samples in late nervous system Lyme disease and cultures. Again, I want you to remember ELISA and a two-test approach. There are other ways you can test. You can see down there, 2 millimeter punch biopsies positive in 50 to 70% of patients. Blood cultures positive in up to 50%. And I gave you some details on each test below. The treatment, doxycycline, 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 doxycycline. Doxycycline for Lyme disease, doxycycline. You do need to know the other drugs.
Yeah, what was it again?
I think it's doxycycline. You don't have to know all of the doses, right? Not for our test, but definitely be familiar with the dose for doxycycline. And know that you can also treat it with amoxicillin. You can treat it with cefuroxime. You can treat it additionally with azithromycin as well. But definitely, I want you to remember doxy in a patient with erythema migraine. that presents to your office if you suspect Lyme disease. Amoxicillin is probably the preferred in pregnant women and, kids under 8. So you have all of those different stages and the different things that may occur in those stages, like the facial palsy, or you're still gonna treat that with doxy. And then you have your alternatives. So you should know the drugs that you treat, which is the treatment of choice is doxy. So doxy, amoxicillin, serofoxamoxicillin. In CNS is a little bit different. If you suspect meningitis is present, you probably need to do IF ceftriaxone or penicillin G. If those aren't available, oral doxy. If you all miss doxycycline on the test, it better be 100%. All right, arthritis, doxy, oral doxy or amoxicillin. Additionally, for arthritis patients, you can do IV treatment as well, which are just as effective. They're equally effective. It's reasonable to start a patient on doxy for 28 days if they present with arthritis that you suspect may be from Lyme disease, or you confirmed and they are presenting with symptoms later in one of those other stages. Here's a chart just to kind of familiarize yourself if you like charts better than the slides. But I need you to remember doxycycline is the drug of choice in Lyme disease. Be familiar with the alternatives, amoxicillin, cefuroxime, ceftriaxone, and cefotoxamine, but always remember doxy. Okay. Additionally, those patients might need symptomatic treatment. The very last line, prolonged antibiotics, not recommended in chronic Lyme. You just want to do an initial treatment. So for our therapeutic procedures, the tick bites, no treatment in most circumstances. You just observe, see, oh, I came in, I have a tick bite. Does not mean you're just automatically gonna give them doxycycline. Want to observe, okay, here's what we're looking for. If acute arthritis, you might need to aspirate to rule out pyogenic arthritis. If they have neurologic symptoms, you may need a lumbar puncture because drug and duration of therapy are unique for nervous system Lyme disease. And if it's a peripheral neuropathy, you can perform nerve conduction tests. Prophylaxis. I did come in, I was in a high tick habitat that's potential for Lyme. Then you may want to treat with a single dose of doxycycline, 200 milligrams, if they meet the CDC requirement, which I gave you a link there. But it tells you, like, has it been within 72 hours from your bite? Have you experienced that or not? It's several questions that basically will tell you yes or no, you should treat them based on that criteria. Do they have a skin rash or, there are several questions you can go through. So I would have you take a look at that link when you have time. Prevention, avoiding tick infested areas, covering exposed skin, using repellents and inspecting for ticks after exposure. These patients usually recover in 4 to 6 weeks after therapy. The long-term outcome of adult patients with Lyme disease is usually favorable. Long-term sequelae are uncommon. Fatigue, arthralgias, myalgias may persist for weeks or months, but do not require antimicrobial therapy. After treatment of arthritis and arthralgias, they may persist and be severe. If it's not resolved after 3 months, you might need to do another course of antibiotics. When do you refer? So you need to do a consult with ID for someone who has experience in treating Lyme disease if it's an atypical or a prolonged case. So you treated them, 3 months later, they're still complaining. Maybe before you do that second dose, you may want to consult with ID or somebody who specializes in Lyme disease. Or you may want to go ahead and do your treatment and then refer afterwards. Some patients will need to be admitted, those with symptomatic CNS or cardiovascular disease. Any patient with Lyme that has a 2nd or 3rd degree AV block or first degree glomerulopathy or interval over 300 milliseconds. But just remember the treatment, prevention, what you're looking out for, different stages, and consult if needed. Your differential, several things on there. Another vector we haven't talked about, alpha-gal. What causes alpha-gal? Does anybody remember? Have y'all talked about alpha-gal? Spot Lone Star tick, yeah, it's an allergy. We've seen it in allergies department, in my allergy department. But typically, the tick puts alpha-gal in the body and creates like a immune, like a hypersensitivity, like a reaction. The immune system is out of whack, so they have allergies to red meat, organ meats, red, like beef, pork, lamb, organ meats, and then like gelatins and other things like that. There's no treatment, they just can't eat red meat anymore. You may learn about that later. I believe Professor Newman knows my about that. That might be one of hers. All right, the next vector is another tick. We're gonna talk about Rocky Mountain spotted fever, which is a serious tick-borne illness, can be deadly if not treated. Mortality rate is 70% if you don't treat it. 70%, that's a lot. That's a lot. It's spread by several species of ticks in the United States, including the American dog tick, Rocky Mountain wood tick, and brown dog tick. And on this map, you'll see where each of those ticks reside. Maryland is going to be in that brown dog tick, American dog tick. And then you'll see Rocky Mountain more on the west coast. But you can see that variety where they are usually found. American dog tick in California, sorry, Sid.
All right.
So we'll look at Rocky Mountain spotted fever. It is caused by Rickettsia rickettsii, which is a gram-negative bacterial parasite spread by certain ticks or tick bites. Most cases are in only 5 states: North Carolina, South Carolina, Tennessee, Oklahoma, and Arkansas. They usually occur during the late spring and summer, usually probably when people are outside more. So immediately, if we had to guess the type of drug we're going to treat this with, we know that it's a gram-negative bacterial parasite. What are we thinking? Antibiotics. The doctor. So yeah, it's going to treat with the antibiotics. Despite its name, most of those cases are outside of the Rocky Mountain area.
Witchy.
Initial symptoms after the tick bite,
No, it's
usually there's an abrupt onset of fever, chills, headaches, nausea, vomiting, myalgias, restlessness, insomnia, and irritability. Abrupt onset of fever and headache, abrupt onset of fever and headache, and a characteristic rash. This rash begins as faint macules and then progresses to maculopapules, then petechiae. You can see in that picture all those tiny little petechiae. Initially involves the wrists and ankles and then spreads centrally to the arms, legs, and trunk, involving palms and soles. We talked about involving and sparing palms and soles to help you differentiate. This one involves the palms and soles. Patients may have facial flushing, conjunctival injections, red eyes. Others may have cough or pneumonitis develop. Severe cases, delirium, lethargy, seizures, stupor, and coma. What I need you to remember is headache, fever, rash. Headache, fever, rash, headache, fever, rash. Need to be thinking about Rocky Mountain spotted fever, headache, fever, rash. When you think about what that rash looks like. Additionally, some patients may have splenomegaly, hepatomegaly, jaundice, myocarditis, which mimics acute coronary syndrome, adrenal hemorrhage, polyarticular arthritis, and uremia, occasionally present. You can see more pictures of that petechial type rash on the feet and look at it on the palm of the hand. About 3 to 5% of recognized cases in the United States are fatal. How do we treat or how do we diagnose? Some patients may have, evidence of thrombocytopenia, hyponatremia, elevated amniotransferases, and hyperbilirubinemia. The CSF may show low glucose concentration and mild pleocytosis, which is just an increased cell count, particularly white blood cells. Immunohistologic staining, or PCR, for R. rickettsia in skin biopsy specimens and serologic testing are the keys to a definitive diagnosis. Serologic testing, serologic testing, serologic testing. So staining or PCR and serologic are definitive in your diagnosis, but for you, primary care, you're probably gonna start out with serologic testing, like I said. You sometimes have to do that, in certain cases with that one, so. Treatment. Man, you guys are good. Doxycycline. Doxycycline, recommended for all ages this time, including children, including pregnant women. It is the most effective at preventing serious complications. Remember, the mortality rate is 70% if untreated. 70%, that's a lot of people. So you need to treat with doxycycline, warn about the risk. Or you can treat with chloramphenicol as an alternative. It is the only alternative to treat this disease. You have to be careful with it because it can cause bone marrow suppression and anaplastic anemia. So doxycycline is your treatment of choice in all patients. All patients, even pregnant, even children under 8. If you have to give chloramphenicol, just remember the side effects: bone marrow suppression, anemia, anaplastic anemia. Prevention of tick bites. You want to wear protective clothing, so tick repellent chemicals and removal of the ticks may be helpful. There was a study a few years ago that conducted a large evaluation of pet ownership, human tick encounters, and tick-borne diseases showed that pet owners, whether they own dogs or cats, were at an increased risk of encountering ticks, and suggest that the pet owners are at an increased risk of developing tick-borne disease. It's small, but they warn if you have a pet, why you should be getting your pets when they go to the vet, getting those certain tick related treatments, tick control products. Differential is several different things. So, this is 5-year-old Mason. Mason was on a trip to his grandparents' house in Georgia when they noticed a small tick burrowed in his belly button. Grandparents picked out the tick and Mason went home. His parents thought nothing of the incident until the next day. They noticed his belly button was red and looked infected. His mom said it looked really nasty and infected, and she just wasn't sure, it just didn't look right, so she took him to the doctor. The doctor prescribed him with a 10-day course of antibiotics, sent him home. On day 10, got through all the antibiotics, this rash appeared. That's unusual, they thought. Mom took him back to the doctor. Doctor's baffled, not really for sure, said, must be a delayed reaction to the antibiotic. Just take him home. This could last 6 weeks. Remember, mortality, 70% untreated. 70% untreated. Mom didn't like that answer and said, I'm gonna start looking up stuff. So she recruited family members. They started looking for diseases, things that matched his symptoms, and they came up with Rocky Mountain fever. Rocky Mountain spotted fever. Went back to the doctor and said, I think it's Rocky Mountain spotted fever. Doctor said, I don't know. Did their own research and said, you're probably right. It's Rocky Mountain spotted fever. They treated him and his spots cleared within 3 days. And that's Mason after treatment. So, just goes to show you, listen to those nagging parents. Sometimes they're right. They know their child best. So keep your mind open. Don't always slam down. Oh, they don't know what they're talking about. I'm the one that went to school for this. You know, if it doesn't sound right, doesn't make sense, maybe you should at least entertain it and think about it. So this concludes the ID series. I know it was a ton of information. even for me, coming from ENT, I'm like, oh my gosh, there's so many diseases, so many bugs, so many parasites, so much to try to keep organized in your mind. I hope that the slides are helpful. They are not my own. I've adapted them. So if you have any questions about anything, please let me know. I'll do my best to try to answer your questions. I do appreciate your support on my first teaching series. It will do better. Sorry, not for you, but maybe for the next one. But I do appreciate your support, in hanging out with me and just being open